Good morning. How's
Good morning.
Good morning. Good morning. Good to see you, Charleston. All right, we'll give it just a couple minutes for people to sign on. Some people might not be able to, depending. Things are fine here, but I know last time we had a snow, we lost power. So I know that some people might be in that predicament.
Oh shoot! It actually snowed.
Yeah. It's nice. It's like, at least where I am, there's maybe 2 inches, probably like 1.5 inches.
Newport News got it pretty bad.
Did they?
Yeah, there's a few inches outside and a lot of ice on the ground.
Yeah, the roads weren't too bad. Queens was delayed 2 hours, but I just got her there and back, got back here, no problem. So at least down here in Virginia Beach, it's not awful. So alrighty, well, while other people might be signing on, I figured again, since we're all just getting to know each other, we'd start by just doing quick introductions today. So you can just do name, and then one thing I realized I forgot to ask you on Tuesday was your class year. So you can just do name and class year. I'm going to call on Haley because she's next to me, and then same thing we did on Tuesday, just after you introduce yourself, call on somebody else.
So just name and class year. Okay, my name is Haley Witt and I am a sophomore. And I'll call on Jenna.
My name is Jenna Nixon and I'm also a sophomore. I'm gonna call on Anaya.
I'm Anaya and I'm a sophomore as well. I'll call on Maddie.
I'm Maddie and I'm a junior. I'm going to call on Ryan.
Ryan, you there? Just, if you're talking, you need to unmute. All right, well, let's skip Ryan. And the next person I see close to me is Logan.
I'm Logan. I'm a sophomore. Sydney.
Oh, Cindy, it looks like you unmuted, then remuted yourself.
Hey, can everyone hear me? Okay, I'm Sydney and I'm a junior and I'm gonna pass it to Kayla.
Hello, I'm Kayla and I'm also a sophomore. I'll do Brittany.
I'm Brittany and I'm a sophomore too. I'll pass it to Sasha.
I am Sasha and I'm a sophomore. I'll just do Charleston.
I'm Charleston and I am a senior. And I'll go to Madison.
I'm Madison Hudson and I'm a sophomore. Thea.
My name's Sophia and I'm a junior. I don't really know who else hasn't gone.
Let's see. I think Madison Rose hasn't gone. We do have 3 Madisons, so.
Yeah, it was confusing me. I'm Madison Rose and I'm a sophomore. I will call on Romina.
I'm Romina and I'm a senior. Did Miranda go? I'm not sure.
No, I haven't. I'm Miranda Hansford and I'm a sophomore. And I think Allie's the only one left.
Hi, I'm Allie and I'm a senior.
Awesome. So mostly sophomores, but some juniors and seniors. That just helps me kind of know where we're at. Awesome. And then starting Tuesday, I will just take attendance based off the participant list. But I wanted to get your class years and then also let you all hear each other's voices again as well. So today we are actually going to dive right in and start talking about all sorts of abnormality. So I am going to go ahead and get our PowerPoint going. And so this class will be fairly lecture heavy, but as I said on Tuesday, certainly always feel free to ask questions, things along those lines. So I'm going to share screen here. Alrighty, and then I'm going to make sure that my clicker is working. Good morning, clicker. It's time to wake up. There we go. That looks promising. Okay, so like I said, when I lecture, I'm going to try to, as much as possible, replicate what it would be like to be in class with me. So I'm going to stand. I just find that it's a little bit easier for me to talk for that long when I stand. And it's just been a minute, so I just need to adjust this to the right height. Yeah, I bought a music stand just because it was the easiest podium, cheapest podium to have at home. And then I rejoined my church choir, so now I use it for that. So you just never know what you'll be able to do here. All right, so I'm going to pull out the chat. If you have any questions, you can either unmute and talk, or you can write in the chat. And I have one eye on that, and I will be able to see. All right, and just a reminder that the PowerPoints for my lectures are posted on Blackboard because I do talk fairly quickly. And again, there are PDF versions if you're someone who likes to print things out and handwrite, or there's the PowerPoint versions, so you can just type in the notes section or, take screenshots and use a Word document, whatever works best for you. But I highly, highly recommend that, just because then you're not worrying about trying to write down what's on the slide. You can just listen to what I'm saying and take notes outside of what's on the slide. So today we're going to start talking, like your book does in the first chapter, about what is abnormal and how is abnormality defined throughout history and how is it defined today. And a big part of what we'll talk about, not only with this lecture, but when we start talking about models of abnormality next week, is who gets to make these decisions, right? Because that's a big piece of it. Something that might be considered abnormal at one time might be considered perfectly normal at a different point in history. So first off, like the rest of psychology, abnormal psychology is a science. And typically, interestingly enough, abnormal is often just called that when we teach it at the undergraduate level. At the graduate level, if we were doing a class like this, it'd be called something like adult psychopathology. And a degree in this would be something like clinical or counseling psychology. But we use this term abnormal for our undergraduate courses, which in my mind gives it a nice frame to be able to talk about, again, who gets to decide what's normal, what's abnormal, when do we decide someone crosses that threshold and needs help, things along those lines. But it is a science. Psychology is a science. Psychology really straddles, I would say, natural science and social science. So some of the elements of what we do are very similar to fields like sociology, for example. But other elements of what we do are essentially biology. So it really is an interdisciplinary science in its own way. It's based off research, and it's performed by clinical scientists. And clinical scientists are people who hope to describe, predict, and explain abnormality. So describe, predict, and explain abnormality. So the first time a disorder was ever recognized historically, the person would just write up a description, right? Of like, here's what's happening with my patient. This might be a new thing that we should look at in other patients. And then we want to try to predict. We want to predict things like, who might get a disorder? What can we do to try to prevent a disorder? If we give the person this treatment, is it going to help them or not? And then unfortunately with abnormal psychology, we also need to predict things like, will this person be a danger to themselves or to other people? And one thing that I really want to point out is that in the American media right now, there's a narrative that people who are mentally ill are violent and are the cause of things like school shootings. And I'm not going to say that none of those people have mental instability. Some of them may have a diagnosable DSM disorder, but the vast majority of people who would fall under abnormal are not a risk to anybody else. And if anything, they're probably more of a risk to themselves. People with abnormal disorders, diagnoses, are much more likely to inflict pain on themselves, to be a risk for suicide. It's very rare for someone with a disorder to be violent. Certainly it can happen, but also there can be people who have no disorder who are violent. So that's just sort of my PSA in terms of, I think the misrepresentation of people with mental illness in our media right now that really does a disservice to the people with those diagnoses, but also does a disservice to figuring out the root of the actual problem, right? So if we were able to say, oh, this guy who just killed 50 people, right? He was crazy, then we can dismiss it rather than looking at the pattern of, we've had a series of guys who have done this, right? What's happening? So I think that as clinical scientists, we need to always keep things like that in mind. There are also clinical practitioners, and they are going to apply the knowledge. And there are people who are both clinical scientists and clinical practitioners. So they might have a private practice on the side, or as part of their science, they might do therapy. So a lot of clinical psychologists who do the research we really need right now are testing new modes of therapy. And so part of their research is doing this therapy with people and doing assessments to see whether or not it's working. But there are people who just practice as well, clinical practitioners, and they apply the knowledge. So they detect that there's something going on, they assess it, and then they treat it. And we'll talk a lot about that in our fourth topic. But essentially, a lot of what you do as someone who is, say, a social worker or a counselor or a clinical psychologist is assessment. So figuring out what diagnosis this person has, what can you do to help them, and then treatment as well. So I thought I would pull out y'all's definitions that you put in the chat. So thank you for putting those in the chat on Tuesday of what is abnormal. And you'll see there are some themes here. So I've kind of grouped some together. So unusual or not usual in today's society, out of the ordinary, seen as taboo, not normal, not viewed in society as common, doesn't fit the standards of society, not typically accepted by society, different than the majority ways of thinking, goes against the mainstream norms, different, not easily seen as common, hard to explain. Yes, definitely that last bit sometimes, unfortunately. Behaviors, thoughts that cause emotional pain to individuals or others due to being outside societal norms. So what I really liked about this is a lot of you were picking up on the societal norms piece of this, right? Like you have to differ from the norms of society. And we're going to talk a lot about, not only today, but throughout the semester, sort of the framework of that, of like what is considered abnormal, crazy, whatever term we're going to put on it, when is largely due in part to what's considered normal at that point in time. So here are some famous folks who have diagnoses. And some of these are, I think, more commonly known, and some of them might surprise you. So it's really important to keep in mind that abnormality, psychopathology can affect anyone. And also that although psychological problems bring suffering, they can also sometimes be inspirational to that individual and lead to creativity. Also, people who have psychological disorders can be highly functioning in spite of them. And I think, again, that's a really important thing to keep in mind, because there's this stereotype in the movies that if you have a disorder, you're going to be like locked away in an inpatient facility. And the vast majority of people who have diagnosable disorders, you would never know. Like, they just go through life and, you know, they do the best they can, and maybe they're getting treatment to help them, and that's why they're able to do it. So some of the examples here, a lot of people have heard of John Nash from the film A Beautiful Mind. So he won the Nobel Prize in economics, and he suffered from schizophrenia. So again, schizophrenia is one of those disorders that we tend to think is just going to shut down your whole life and you can't function. Clearly, he offers a counterpoint to that. Buzz Aldrin, the astronaut. So he was the second man to walk on the moon, and he suffered from depression. And now he's like a badass. I don't know if anyone has seen footage of him. Like, one of the conspiracy theorists who didn't believe the moon landing was real came up to him, and he's, you know, in his like 80s or 90s now, and he just punched the guy just flat out. Not that I necessarily recommend violence, but like, you know, I understand. He went through a lot to get there, and for someone to just be like, I think it isn't real, probably ticked him off. Winston Churchill, the statesman from the UK, he suffered from bipolar disorder and dyslexia. And many different authors, some of which are probably more surprising than others, suffered from clinical depression. So, you know, someone like Hemingway or Edgar Allan Poe or even Kurt Vonnegut, I think that makes sense to us, but Charles Schultz, the guy who drew Peanuts, suffered from clinical depression as well. And you can see that once you know that in his portrayal of Charlie Brown, right? So Charlie Brown kind of has a lot of the hallmark symptoms of depression. So what do we call abnormality? Well, that's changed over time as well. And like I said, even in today's time, you'll hear different terms used. So abnormality, diagnosis, you know, psychopathology. Sometimes you'll still hear people use really derogatory terms like crazy, nuts, things like that. But this just kind of shows you how over time, different slang words have been applied. So unstable, madness, insanity, distress, disturbed, crazy, unbalanced. Sometimes they just called them psychological. And one thing I'll say is that it really used to be the case that these diagnoses were used to control people and sort of get people out of the public eye who may have been causing issues. So for example, in sort of the 17 and 1800s in the UK, if you had a rich relative and you wanted their money, you could like institutionalize them. You know, you just had to come up with a good story and have a doctor who was willing to do this for money, unfortunately. And this happened to a lot of women who were heiresses, unfortunately. Abnormal, psychopathology, psychiatric maladjustment, mental illness is another one we hear quite a lot. Mentally handicapped or deviant, dysfunctional. Typically in sort of the academic circles, you'll hear psychopathology, I would say, or just talk of the specific diagnosis. But certainly a whole host of terms are still used today as well. Now, in terms of what is abnormal, like your answers, there are a whole host of different things within the field that people have come up with, different theories, different ideas of how to describe this. So Rosenhan and Seligman, these are two huge names in psychology, actually. Rosenhan did a lot of really interesting research about, you know, like who gets to say who's abnormal and what happens to you then. Seligman is really known for his research on learned helplessness. And so they came up with this definition that it's maladaptive, so somehow doesn't help you in your life. It is unpredictable. And what we'll see is that not all these terms are 100% accurate. Unfortunately, there are disorders that are predictable. And maybe that's fortunate, because then maybe we can help the people before it gets too bad, that they're suffering in some way. And that component certainly carries through to our diagnoses today. When we start talking about the criteria for how we diagnose disorders, what you'll see is that like a lot of them will talk about suffering and how it affects your life. Being irrational, the observer being uncomfortable, which I think is really interesting. Again, gets at that sort of societal ideal y'all were talking about. Vividness, violation of moral and ideal standards. And again, sure, there are people who have psychopathology that this would happen with, but there are also people who have psychopathology that, you know, wouldn't fit all of these. So Levine in 1986 came up with more succinct criteria, and he used the acronym IMAD to help remember them. So the I is inefficiency. Essentially, it takes them longer to do things because their symptoms can get in the way, so they're inefficient. The M is misery. That, again, that's that sort of common thread we'll see when we diagnose people, is that it's negatively affecting their life in some way. And in fact, some of the research in the field has really pulled this out as a common factor among people who suffer from mental illness. Alienation, so either the disease itself keeps them isolated. So for example, if you have you know, agoraphobia, which is sort of a fear of leaving your house, right? It's going to actually isolate you. If you have depression, you just might not feel like getting out of bed. But sometimes it's just your symptoms isolate you because other people don't want to be around you. And then there's disturbance. And the disturbance is to yourself as well to others around you. So inefficiency, misery, alienation, and disturbance. Comer, and he established this long ago in his text, and actually, just like a little cute sidebar, I believe it started with the 10th edition. It's actually, your book is now co-written by Comer and his son, who's also a psychologist, so I thought that was really cool. But Ron Comer, the dad, has been writing your book for years, and he came up with this idea, the 4 Ds, defining abnormality. So one is really what a lot of you captured in your definitions, the deviance piece of this, that it's different somehow from the norms of society, that it might be extreme or unusual or even bizarre, although it doesn't have to be, right? So it's deviant from norms, and norms are explicit and implicit rules for proper conduct established by each society, right? So sometimes these are actual laws that you have to follow, and sometimes they are something as simple as, you know, you're sort of shunned in society if you don't act a certain way. And these come from that society's culture. So culture is a really big piece of this. So that culture's history, their values, the institutions that they have, habits that are common, skills, but also things like the arts or technology available to that society, right? But these norms can change as the culture changes. And so I've used this example of Danica Patrick for years. So she is a race car driver. She started in the Indy series and she did NASCAR as well. And to be a female race car driver just wouldn't even have been possible, right? In the past, it just wouldn't have been something they allowed. For example, the first woman who tried to run, I believe, the Boston Marathon, course officials actually tried to pull her off the course. And what was really cool is her fellow runners were like, no, let her run. So the culture can change, and then these norms change, which is good in some ways, but then also means that what is abnormal is elusive, right? It's always changing, always molding. And so that can make studying it both interesting and challenging. Distress, so that it's unpleasant, upsetting, again, to the person most of the time. But sometimes it's distressing to other people. And so, for example, people who are in a manic state will go and be really happy just spending all their money. But the people around them will probably be disturbed by it. Or something like pedophilia, right? The pedophilic, the person with pedophilic disorder, there we go, that's what I want. We don't want to label people with their disorder. We instead want to say a person with that disorder. They don't necessarily feel what they're doing is wrong, but clearly it's harmful to the child. If you, it's not always necessary, again, but it can be other people. And I'm realizing I forgot to mention one thing on the point above with deviance. So if you violate legal norms, you're a criminal, right? But if you violate psychological function norms, then you're abnormal. And again, sometimes those things match up and sometimes those are distinct. And we also have to take the immediate circumstances into account. So for example, after 9/11, we had a really high incidence of PTSD. So unfortunately, it was almost normal, right, to have that. I'm guessing we'll see something similar in the DC area following the events of January 6th. Dysfunction. It just interferes with your daily ability to function. So they can't live their normal life. They sometimes gets to the point where they can't care for themselves. Like I had a very depressed client I saw who could only bring herself to shower once a week. You know, and where most of us do it every day without thinking about it, right? But it just, that took so much energy for her. You know, that sometimes it affects their work. I bet a lot of us have experienced that in the pandemic, right? Like I just am not as efficient at getting things done as I typically am. I'm pretty good with my teaching stuff, but like writing my own research up, it just hasn't been happening. And it can even affect our abilities to socialize. You know, we just might not feel like hanging out with our friends. And then danger to self or to others. So sometimes it can be outright hostility to yourself or others, people who are suicidal or homicidal, but it can be as simple as being careless, right? So like kiddos that have ADHD have a higher incidence of just accidents because they don't pay attention. So they're gonna stumble into things a little bit more and get hurt that way. Some disorders like severe depression or schizophrenia will lead to you just feeling confused, right? Or thinking about something like Alzheimer's disease, right? And then you can harm yourself in that way if you wander from home. So again, the danger to others really is the exception, not the rule in people who have abnormalities. An example is psychopaths or people we would diagnose with antisocial personality disorder, which we'll talk about at the end of the semester. They are truly people who sometimes are your serial killers, and like that is part of their pathology. But there can also be things that are dangerous but not seen as abnormal because they're not uncommon. So I was telling my J-turn class about how we would sort of only half jokingly, when I was seeing college students when I was in grad school, talk about college drinking, NOS, not otherwise specified, because the way that a lot of college students drink if they were not in that context, would be defined as binge drinking and might even meet the criteria for a substance abuse disorder. But because of the context, right, we sort of don't recognize it in the same way. And so it can be difficult to make sure we're looking at things the correct way. So for example, men who come in with substance use issues, not always, but sometimes they're sort of self-medicating to mask things like depression or PTSD. And well-meaning clinicians will just sort of treat the substance use and assume everything will be fine. But in fact, a lot of times things get worse for them because, for example, when I was at the VA working from 2009 to 2010, there were Vietnam vets. So guys from the 60s and 70s were just coming in to get treatment for the first time because they had essentially been self-medicating the whole time, got clean, and then their nightmares came back or their flashbacks came back because they weren't sort of suppressing them with the substances. So that can also be an issue. The other extreme of this can be eccentrics, and it may be difficult to distinguish between abnormality that requires intervention and eccentricity, people who are just kind of themselves, right? So these are people who are have marked individuality, they deviate from common behavior patterns, and they can display odd or whimsical behaviors. And we probably all know at least one person like this. Like, I had a student who I wouldn't say had any kind of mental disorder, but like one day in the spring, she just brought me a crown she made me out of dandelions. And it was like a nice gesture, but also kind of like, okay, right? Like that's something you expect. She was just eccentric and that was fine. Another example is sort of the stereotype of the crazy cat lady, right? Like she's just an old lady who takes care of a lot of cats. Why is that a problem? As long as she's not like in a hoarding situation where it begins to affect her health and the cats, obviously. There is some research that looked at 1,000 people who were defined as eccentrics over a 10-year period. And they found that they don't typically suffer from mental disorders. There's no suffering, no disruption to their lives, no dysfunction. They actually have fewer emotional problems than the general population and fewer physical health problems. And most seem to be happy, well-adjusted, joyful people. And so I think there are probably a decent number of people in our society who are like that. But, you know, depending on their family context or their subculture, or certainly in the past, they may have been branded as abnormal. Alrighty, so Thomas Szasz, back in the 60s, and pardon me for just one sec, actually let me mute real quick. My allergies have been acting up and I don't want to blow my nose right. Alrighty, so Thomas Szasz, and those of you who were in my Theories of Personality class last semester, he'll sound familiar. He was one of our characters in our simulation. So he argued against the idea of mental illness altogether. He said, we assume that mental illness is due to some sort of brain defect. And he said, he really played off a lot of what we've been talking about already in terms of like the societal norms. And he said, you know, it's differences in societal needs, it's differences in opinions, it's differences in social aspirations or values. And mental illness in his time was regarded as no different from a physical illness other than the brain is affected. And he said, you know, a person's beliefs can't be explained by any kind of defect. And he also was sort of playing around with this idea of like the mind-body dualism. Like, is the mind its own thing? Is it within the brain? How does that work? This is a question we've been asking for years, honestly. Philosophers have been asking this before psychology existed. So he defined these instead as problems in living. So he basically said, people have a hard time living within these societal constraints. And that's what abnormality is. So he said mental symptoms are actually tied to social and ethical contexts, but bodily symptoms are tied to anatomical or genetic contexts. And so is mental illness a cause of human behavior, or is it caused by human behavior? And he said it's determined by deviances in psychosocial, ethical, and legal norms, but they're believed to be correctable by medical action. And he believed that society invents the concept of mental illness to control or change people. And he said in particular, the people whose unusual patterns of functioning upset or threaten the social norm. So there is a history of places where people who speak out politically are classified as mentally ill and hospitalized, silenced in various ways. This happened in communist Russia, for example. So certainly there's something to what he's saying, but also he was saying this in 1960 before we had access to things like brain scans to do research and tie things together. So I would say now the conceptualization is really sort of a combination of Saz's ideas about society causing issues and also, you know, brain-based parts of things. It's kind of a mix is, I would say, the overarching explanation in this day and age. Although we'll see different examples starting next week of models that explain it vastly differently. All right, so therapy or treatment is a procedure designed to change abnormal behavior to more normal behavior. And sort of interesting sidebar with this, there are people within certain communities that have certain diagnoses that think that therapy shouldn't be a thing. So for example, people with autism spectrum disorders, not all, but some of them are really against like the Lovaas method or other behavioral things that in like society's mind has really helped people. But those people argue that it in fact is just like changing them, and their only problem is they are neurotypical. So again, treatment is generally seen as a good thing, but not always. So keeping that in mind. So Jerome Frank did a lot of really interesting research about sort of what are the common factors in all types of therapy. And he said that every type of therapy has three main components. You have the sufferer, sometimes we call them the patient, the client, the consumer, but they are the person seeking help. And they seek help from the healer. And the healer is the therapist, again, whatever level of training they have, and they're socially accepted as someone who can help people who are sufferers. And then there's a series of contacts, and those are your therapy sessions. And the healer tries to produce changes in the sufferer's emotional state, their attitudes, their behaviors to help that person suffer less. So some of these other common factors he came up with was the therapeutic bond, the strong therapeutic relationship between the client and therapist. And really, research over and over has shown that regardless of the type of therapy you are doing, this is the most important component. If you don't have that, like therapy is not going to work. You need to have a healing safe setting. So that's a challenge, right? In COVID times, when a lot of times this is how therapy is being done, right? Does that work for people if their family is around? One of our alums, Taylor Doty, just actually defended her dissertation for her PsyD yesterday, and because it's on Zoom, I got to watch, which was really cool. But she did her project looking at helping women with who are survivors of interpersonal violence, and like the problem she would run into is like some of these women were at home with their abuser, right? So like, how do you do that session at that point in time? Ideally, this is in a safe place, right? COVID makes that challenging. You need some sort of rationale for why the healer's doing what they're doing. there's some sort of ritual that's performed in your contacts. So that could just be coming into the same room together. It could be in some types of therapy, they actually set an agenda for each session. And then the biggest thing I think that is besides the therapeutic relationships, number one, the second biggest thing for me at least is that the sufferers have to want help and be willing to work for it. The therapist can't do it on their own. So back in, gosh, I think when I was in grad school, so something like 15 years ago, Tim Gunn got his own show, and he would work with women to like redesign their wardrobes. And I remember him saying to one of the women, like, I can't want this more than you want it for yourself, right? And I actually like would use that with clients when I saw them, because they have to want to change. Otherwise you can do all the bells and whistles, right? And it's just not gonna work for them.
I have a question. So in that case, how do you work with people whose disorder actually is characterized by them not wanting to change? So maybe psychopath, or what you were saying about people who have suffer from pedophilia, people like that.
That's a really good question, Romina. Thank you for asking it. And the answer is we don't have good treatments for those things still, as much as we've been doing research on that, particularly antisocial personality disorder. It's so hard to change them because, like you said, they just don't want to change. They don't feel like they need to change. For pedophilia, we're able to do some behavioral things. So, you know, with the person's consent, applying light shocks when they view something, or when I teach my clinical class, there's a case study we read about a man that they just had him envision throwing up, which he hated when he was confronted with like child porn imagery. But yeah, we don't have good treatments for those things because of that, I think partially. And actually one of the worst things you can do for people with antisocial personality disorder in particular is group therapy, because they just get ideas from each other. Yeah, so we're still working for that is the answer. And a big part of it is they don't want to change, so forcing them to change just doesn't work. Really good question. And that can happen too with people who are just like forced to come to therapy by their families, or forced to see a type of therapist they don't want to see, right? And so we might have to work really hard to overcome that. So part of the therapist's role is really to be warm and show empathy and to build a strong relationship regardless of what's going on with the client. But yeah, that's a really good question that unfortunately we don't have answers to for everything yet. So abnormality is actually fairly common, which is kind of funny if you've given the name abnormal, right? But something like 30% of adults and something like 19% of kids and adolescents will experience some sort of serious psychological disturbance that should be getting treatment, but I would say probably the vast majority of them don't, and largely because of access issues to treatment. It's really difficult to find a therapist who takes your insurance. What if you don't have insurance? But also the stigma of therapy that's still in our society, which is really unfortunate. Depression is probably the most common one that we see. So somewhere around lifetime prevalence of 10 to 20% for women and 5 to 12% for men. Schizophrenia, much less common. So only like 0.5% to maybe 1.5% worldwide. So it's interesting. Some of the disorders that are the least common are the ones we see the most in pop culture. So this is something to think about as you think about that media project that's due in a couple months, is like we see things like schizophrenia and dissociative identity disorder, which used to be called multiple personality disorder, over and over in film and TV shows. And I think it's because that people think it's interesting. It's almost this like specter of this severe psychopathology. Whereas, you know, what we see most often are actually these mood and anxiety disorders. And I'm used the word prevalence here just to sort of clarify. Prevalence is just the number of cases that exist right now. So it's the percent of the population who have that disorder at any given time. So prevalence is how many people have it right now. Incidence is another term you'll hear, and incidence is the number of new cases during a given time. So it could be, you know, the number of new cases of depression over the course of a year, or unfortunately in the society we're living in right now, the number of new cases of COVID that we're seeing daily, unfortunately. Everybody wear your masks, be safe, social distance. All right, so now we're gonna go way back in history and start talking about how we have viewed abnormality over time. And so psychology itself as a science is a young field. It really started in the 1870s. But the idea of abnormality has existed since humans existed. So we do have some prehistorical and historical ways that people have looked at abnormality that I think are really interesting to study and also important to study. Because if we don't know sort of what we've done wrong in the past, right, we can't correct things now. So in ancient times, abnormal behavior was seen as the work of evil spirits. Demons, ghosts, you know, depending on the culture, maybe you were being revisited by, you know, an ancestor who was unhappy or something along those lines. And when a person acted oddly, they were possessed by those spirits. So one of the ways that they tried to remove evil spirits was by drilling holes into skulls. And this process is called trephination. So here on the screen, you can actually see a skull that has the holes in it. And they did this for a while. So this is, I believe, from like maybe the 1600s, could be a little later. And this was a, like, basically kind of like a mannequin head they used to practice trephination on. The idea was they would let the spirits out through these holes. I mean, no, right? And then like the problem was you were doing this in a time where you didn't really have anesthesia, you didn't really have proper methods for reducing infection potential. So like some people survived, right? But I guess you killed the evil spirits by killing the person sometimes. Not great, right? The other way, and sometimes combined with trephinations actually, that people would try to do this is exorcisms. So again, this I think has a really like stereotyped cultural, especially from the movie The Exorcist, right, the horror film. But this was a ritual. It was a religious ritual. It would be a shaman or a priest, and they would recite prayers, perform magic, have the person drink potions to try to rid the body of those spirits. So that was the idea. And so we know that ancient peoples were thinking about mental illness and how to describe it as early as ancient Egypt and ancient China. So in ancient Egypt, we've actually found the first known historical psychiatric text, and it describes hysteria. And I'll throw that in the chat just in case you don't know how to spell it. Typically I'd write it on the board, but I don't have one. Okay. And this term was really used until the early 1900s. So this term stuck around. And so the literal translation of hysteria was wandering uterus. And the idea was that women developed this disorder because their uterus picked up and wandered around their body, like you do. And it would essentially lodge itself from in another place, and that would cause problems. So one of the things that happens in what we now call somatoform disorders is that people will get physical symptoms that have a psychological cause. And so they might have like numbness or paralysis in a limb that's not explained by anything physical. And so the idea was, let's say this arm was numb, it's your uterus had just, it's hanging out in your shoulder. Again, like you do. And so, and it would also cause symptoms like pain and sadness and distress. So the interesting thing is that term stuck around even after they realized that the uterus wasn't actually wandering around. right? And in fact, we still use this term today, often to describe women who are being overly emotional, right? Hysterical, you're hysterical. So again, really interesting to think about how some of this terminology stuck around. In ancient China, they thought that the human body has both a positive and negative force, the yin and yang, which in the 90s was really trendy to wear as like a necklace, right? Sort of weird. And when one takes over, so like the yin, there's too much yin or there's too much yang, that's when abnormal behavior results. And the typical ways of healing people would be starving them into depleting their excessive force and try to create that balance of harmony in them. And to some people, that sounds like barbaric or bizarre, but Western cultures also believed this. So the ancient Greek and Roman cultures were the first to develop names for mental disorders. And some of these terms we still use in some ways today. So melancholia, unshakable sadness, we still talk about people who are depressed as melancholy, right? Mania, we still use this term, and they defined it the same way we did. Euphoria and frenzied activity. Dementia, general intellectual decline. Again, good old hysteria. But for them, they were defining it as a presence of a physical ailment with no apparent physical cause. Delusions, blatantly false beliefs, and hallucinations. Imagine sensory experiences as if they were real. So again, many of these terms we still use today, so they were starting to give us some of this. Hippocrates was considered the father of modern medicine, so people who become doctors still take the Hippocratic Oath, named for Hippocrates. And he and his associates left a body of work called the Hippocratic Corpus, corpus meaning body, in which they suggested that psychological disorders could be treated like any other disease. They came up with the idea that psychological disorders could be caused by something like head trauma, or brain pathology, or influenced by genetics. They considered the brain the seat of wisdom, and of consciousness, intelligence, and emotions. And that doesn't sound radical to us today, but at the time it actually was. So the Egyptians, again, having written the first psychiatric text, thought the brain was an organ of no importance, and would just, when they mummified people, they often preserved organs, but the brain they would just pull out through the nose and discard. So again, it was kind of revolutionary at the time. And his ideas were adopted by Galen, Galen, who was a Roman physician. And Galen and his associates created a powerful and influential school of thought that extended well into the 19th century. And this was really based around the 4 humors. So Hippocrates developed these, and then Galen and his colleagues adopted them. And so very similar to yin and yang, but now there's 4 instead of 2. The idea was that if any of these are out of balance, if you have an excess of one of them, that would cause not only mental disorders, but also physical disorders. So blood, they thought if you had too much blood, it would cause moodiness. A common treatment for not only physical disorders, but mental disorders was to bleed someone. So they would actually just make a small cut and let that person bleed. This copper cup you see here is an example of a cup they would use to catch the blood. Or sometimes they would apply leeches as well. Phlegm, if you had too much phlegm, they thought it would cause fatigue. Yellow bile, too much of that would cause depression or sadness. Black bile, if you had too much of that, it would lead to aggression and anxiety. And here is a medieval depiction of the consequences of those 4 humors. So we had all this, like great advancement in the Greeks and the Romans, really thinking about things. And then in the Middle Ages, it just went all out the window. So these are medieval times. There was a growing distrust of science. Sounds a little familiar. But this led to a resurgence of ideas from ancient times that abnormality was caused by evil spirits. And here they were personified by Satan rather than, ghosts or demons. During the Middle Ages, there was on average one church for every 200 people. So I actually have a picture of Notre Dame here, pre-fire. This was the type of thing people put their money and their efforts and their time into, right? It was places of worship. So religion was a huge part of their life. So the church was a big part of deciding sort of what was normal, what was abnormal. And one of the things that happened during the Middle Ages quite a bit was what's called mass madness. So one of the examples here is tarantism. People would jump and dance and convulse, would shout, rave, and this is where the dance, the tarantella, gets its name from. And actually, the term rave, which we think of like the party with the glow sticks, right, came from this sort of mass madness description as well. It seems really odd now, but not that long ago, in 1992, there was an example of 21 people at a school having to be rushed to the hospital after developing dizziness, headache, nausea, and stomach pain after one girl said she smelled something coming from a vent. There was no physical cause, no physical problems with the patients. They were sent home and recovered quickly. So humans are very susceptible to the power of suggestion sometimes. Also in the Middle Ages, we had some fun mass madness. So we had lycanthropy, which was werewolfism. And that's actually what this other diagram on the page is. People would actually think they were wolves or act like wolves. And then witches. So really from this point on through into the 17 and 1800s, madness was viewed as witchcraft. And many were punished or executed. So in some of my other classes, I talk about Grace Sherwood, who was our local witch, which Duck Road is named for her. And so the punishment or the test for her was what was called ducking, where they would tie you up, I think to a chair, and then they would submerge you in water. And if you floated, you were a witch. But if you sank and I guess drowned, then you were innocent. Right, so again, this is how a lot of people who were outside the norm, women who did things like practice herbal medicine when they wanted that to be, like medicine to be the purview of men, would be executed, burned at the stake often. Alrighty, and then during the Renaissance, so we think of the Renaissance as this very enlightened time, and in mental health, kind of a mix. So Joseph Weyer was the first physician to actually specialize in mental illness. And he said the mind is as susceptible to sickness as the body. So he's really the founder of the modern study of abnormality, psychopathology, whatever term we want to use. And around this time, what also started to develop is community mental health. And it's really a precursor of a lot of the efforts being made today. So there were religious shrines devoted to humane and loving treatment of people with mental disorders. And one of the examples here was Wiel in Belgium. So it really focused on loving care and treatment. People would come from all over the world to seek healing at the shrine, and local residents would welcome pilgrims into their home. So these people who had mental disorders would be invited to stay with residents of Wiel. And so this really was the first colony of people with mental disorders. And it demonstrates that people with psychological disorders can respond to loving care and respectful treatment, like they didn't have a lot of problems because it went really well. On the other side of the token, the way that they really treated a lot of mental illness here was institutionalization. So asylums were founded to care for people with mental illness. They were often converted hospitals or monasteries. Sometimes they were built from scratch. And they were founded with the intention of good care, and they really just became prisons, to be perfectly honest. There were filthy conditions and patients were treated with unspeakable cruelty. The very first asylum was in Muslim Spain in the early 15th century. Probably the most famous or infamous is Bedlam. And that's what this line drawing is on the page. So, you know, we now associate the word Bedlam with like chaotic uproar, and it came from this institution. So it was actually called Bethlehem Hospital in London, and it still exists. There's a version of it that still exists today. So in 2017, I went with a group of 19 students to London, Paris, and Amsterdam, and we went on a walking tour of sites related to Bedlam, and we read about Bedlam. And, you know, just like any other institution, you get someone who is crooked in there and they're just taking money, and, you know, the patients suffered as a result. So patients were kept in chains. This diagram, this picture here is actually a picture of some of the restraints that were used for people. And they cried out, but what this picture is actually depicting, which is really disturbing, is it was a tourist attraction. So people would go and they'd pay a couple shillings or what have you to look at the howling and gibbering inmates. Again, as if they were going to the zoo or something like that. And this would also happen in Vienna at the Lunatics Tower. Patients were herded into narrow hallways by the outer walls so that tourists could look up and see them. So again, awful treatment, awful that this was seen as just a spectator sport. But again, I think there are elements of that continue into today in terms of how mental illness is represented in pop culture and things along those lines. And as I mentioned before, a lot of the patients in asylums from all classes and all circumstances were women. So women who dared to speak their minds, women who had opinions, women who had money and their families wanted it, would end up hospitalized and unfortunately live the rest of their lives in these horrible conditions.
Did the great desire to like view these people in like the accessibility, you know what I'm trying, I'm sorry. But you know, the being able to pay to go see these people, kind of like you said, treating them like a museum, did it come to a point where it was outlawed legally, or did it kind of become a trend that died off?
I think it was just a trend that died off. As far as I know, they never officially outlawed it.
Wow, okay.
Just, yeah, people were just like, maybe this isn't the right thing to do after a minute. And so what you see here are actually images from that walking tour. And so this was our great guide. His name was Berwin, and he like had made discoveries for the Freud Museum and things like that. Like, he was just a really cool guy. And so this was the first Bedlam, the first Bethlehem Hospital, and now it's like a train station. And then this was the second one. And as you can see, now it's a Pizza Express. And then here is, we weren't able to actually go because they were undergoing renovations, but this is a really blurry bus picture of the current Bethlehem Hospital, which does still exist, but has a completely different view on things. And is very much sort of like run partially by the patients, and they do a lot of art therapy and things along those lines. So, but yeah, really interesting part of London's history. Here are some more. We actually were able to go to an exhibit all about Bedlam while we were there. So they have more things like restraints that they use. These are pictures of what it actually looked like. This was really interesting. So this, I believe, was the second Bedlam, and it looks like this really grand place, but it was only like a room deep. We just tried to make it look a lot cooler than it was. It was just long, not wide. And here's an example of when they started to become more enlightened. And so you see, there's not tourists. There's people, they're actually able to walk around. They're not confined in cells. And again, here there are residential services. There's a mother-baby unit, which is unusual. Anxiety disorders. And again, studio facilities for art, woodworking, and textiles. And they had some of their art on display as part of this exhibit, which was really cool. Alrighty, so moving into the 19th century, we're taking the good ideas and trying to move those forward. And so moral treatment was really the main idea here. And it was developed by Philippe Pinel in Paris. The idea was to treat mental patients with sympathy and kindness, free from chains, free and having sunny rooms, support and advice. So like that later picture of Bethlehem Hospital, having supports for them instead of treating them like prisoners. I don't have his name on the page here for some reason, but there was also a man named William Turk in the UK who developed something called York Retreat, where it was actually a rural estate, and he had 30 mental health patients come and live as guests, essentially. And they had houses, and they were treated with rest, talk, prayer, and manual work. So some ideas about, kind of going back to Geel, right? The idea that like you can live together and work together, and that's going to be part of your rehabilitation. Rush, Benjamin Rush, was the founder of moral treatment in the US. And the idea was we're going to have intelligent and sensitive attendants, therapists. Rush is considered the founder of American psychiatry. And he used treatments that we think would be really good if we think about things today. So love and kindness, the attendants reading and talking to patients, taking the patients on walks. But then he also had some that, again, at the time were considered caring, but would probably shock us today. So still using bleeding, laxatives, substances to cause vomiting, scaring the patients, spinning patients around, pouring ice and cold water on their heads, dunking them in ice water or putting them in baths, raising blisters on their head and neck, then rubbing salves into them. And he also had something called the restraining chair, which I believe is in your video assignment on Launchpad. So again, it was considered more humane at the time, but by today's standards, we're like, what? So the restraining chair, so yeah, I have my chair right here. So they would actually be in this chair, and put my camera back down. And their arms would be held in place, their legs would be held in place, there would be a hole in the seat for any excrement, and then there was like a part that went over their head with like a veil, and the idea was it was supposed to help them calm down. And like, maybe, but also you're just being confined, right? It's not the greatest treatment, especially, let's say if you had someone who had like claustrophobia. So again, this was progressive at the time. Now we'd be like, what the heck? So that's something to keep in mind, is like probably things we're doing now in the future. Someone's going to be like, what the heck? You used to do what to people? Dorothea Dix really strove for humane care. And this is a portrait of Dorothea here. She made it a public and political concern. She went around to different state legislatures and would advocate for them to pass laws to make care better for people. She was horrified at the condition that existed in asylums at the time. She actually helped to establish state hospitals, which, like Bedlam, like Benjamin Rush, started with the best of intentions, became just prisons in and of themselves, unfortunately. And these declined after money shortage. They really weren't always sufficient. There was discrimination, racial, just discrimination based on disorder you had, gender discrimination. So again, there were people trying, but the reality of what happens in the real world, right, would get in the way sometimes. Alrighty, so next we have the early 20th century, so the 1900s, and we had two perspectives here on what caused abnormality. So there was the somatogenic perspective, and this was that physical causes were behind them. So this is throwing back to Hippocrates and Galen, right? So this had been sort of gone for a while, and then it came back. So Emil Kraepelin, who we'll learn about more when we talk about schizophrenia, So he thought that physical factors were responsible for mental dysfunction, and he developed the first classification system for disorders. Before that, we didn't really have a like, this is how you diagnose someone, here are the labels, right? People would just often be called mad. And then one of the things that helped develop this perspective was actually the disease syphilis. So in later stages of syphilis, people would actually develop mental symptoms as well as physical symptoms. So they would have, maybe they would have hallucinations, delusions, things along those lines. And so realizing that here's something we can clearly see that has a physical cause linking to these mental symptoms made people realize like, oh, there's something physical going on. Oops. The somatogenic perspective was psychological. And this actually dates back to Cicero. And the idea is that psychological disturbances cause bodily ails. So kind of the flip of the somatogenic. So some interesting ideas here, but of course, like anything else, they kind of got out there. So mesmerism and hypnotism became part of this. So putting people in a trance-like mental state where they become easily suggestible. Mesmer was actually the first to do it, which is why it was called mesmerism. And he was trying to like help discover underlying trauma in people with hysteria, as it was labeled at the time. So not bad, but then it became like seances and things like this. And if any of you have taken history and systems with Dr. Jackson, you'll know there were like letters from psychologists to other psychologists who were into mesmerism, like, please stop. We want to be a science. Like, please stop. You're not helping. There were also other folks who thought that we should be careful with hypnosis because it could induce hysterical disorders. Charcot was the first to say that hysteria is psychological in nature. There's something mental going on. And so Joseph Breuer, I always butcher his name, poor guy. So he used hypnosis to have patients talk about their problems, and they would emerge feeling better. And Freud actually went and trained with him. And he essentially developed psychoanalysis, which was the first talk therapy based on his experiences with hypnosis with Breuer. He essentially said, okay, so if they feel better when they talk about their problems under hypnosis, what if we just took away the cloak and dagger and just had them talk about their problems? And in fact, he found that worked. So he developed outpatient therapy and realized you don't have to use hypnosis to do it. Alrighty. So in terms of current trends, certainly the advent of medications, they really started around like the 1950s, 60s, really changed things. So there are different medications that treat psychosis, antipsychotics, that treat depression, antidepressants, and anti-anxiety or anxiolytic medications as well. We'll talk about those in a lot more detail when we talk about the biological model. And a lot of times now these are paired with therapy. Deinstitutionalization, so in the 70s, those hospitals that, again, Dorothea Dix helped get going with the best of intentions, they realized they're just not working, right? So they shut them down. Problem was, a lot of people who were in them, not all, but didn't have a way to care for themselves, couldn't care for themselves, and so ended up homeless, unfortunately, and jobless. Now we tend to do short-term hospitalization. So if someone's suicidal, they make it like a 72-hour hold, something along those lines. And again, do outpatient therapy and medication. Community mental health care is another aspect of this. So trying to get people's doctors and psychiatrists and psychologists and housing, all sort of working together. I actually have a friend who is a social worker that this is a lot of what his company does, and he's sort of in charge of it now. And it's tough work, but important. So let's go ahead and stop there for today, and we'll pick up talking about therapy on Tuesday. Since we only have about a minute left. But I will stick around in case anybody has any questions. And if not, take care of yourselves. Go have fun in the snow before it melts. And I will see you all on Tuesday. Have a good weekend.
Bye. Thank you.
Have a good weekend.
You still there? Yes, you Oh, okay. Yeah, my question is, well, so like as far as the internship class, right? Well, again, apologies for Monday. But with the internship, I end up having to go into a quick quarantine when the week started because of I'm negative. I got my test back saying I'm negative, but because another person had tested positive, they had a family member that I knew and they tested positive, all that good stuff. So I had to wait. So I had been unable to unable to get my fingerprint card that I needed for